So here we have a normal ECG trace. Here we have the P wave, which relates to atrial depolarization, the large QRS complex, which relates to ventricular depolarization, and then the T wave that relates to ventricular repolarization, which is generally positive. Notice that there is no wave for atrial repolarization. That gets swallowed up by the QRS complex. So often when you see an ECG trace, it's written on a graph, and on the x-axis 1 millimeter here is one small box, relates to 0.04 seconds because it's a graph with time on the x-axis and voltage on the y-axis, and one small square on the y-axis relates to 0.1 millivolts. So here's a diagram of the electrical wires, if you like, of the heart. The SA node is always emitting a electrical pulse that is then picked up by the AV node here, and this goes through the bundle of His through this junction, and then splits into the right bundle and the left bundle that then go round to supply the left and the right ventricles simultaneously, which in turn makes the heart muscle contract and pump out blood. This is again just to show you what's happening at the P wave. This is where there's atrial depolarization. Then there's a slight delay while it's conducted into the AV node. Then the electrical rhythm is passed through the His bundle of His and into the left and right ventricle, and that depolarizes the ventricles in the QRS complex. Next, there's the depolarization that happens in the ventricles, and then the repolarization that begins, which creates the T wave, and that's the complete electrical cycle in the heart. So to summarize this, the P wave relates to atrial depolarization. The normal time that takes is about 1.2 seconds, which is equivalent to 3 small squares on the ECG trace, assuming it's going at 20 milliseconds on the paper speed. The QRS complex relates to ventricular depolarization. Again, it's the same time as a P wave. It's about 0.12 of a second, 3 small squares on an ECG trace. The T wave relates to ventricular repolarization. There's no strict criteria for this, but you do need to look at the ST segment for changes, whether it's depressed or elevated, whether there's ischemia or infarction. The PR interval, which is measured from the beginning of the P wave to the beginning of the QRS complex, should range between 0.12 to 0.121 seconds. That's equivalent to 3 to 5 small squares. If it's longer than that, then you've got heart block. So I want to give you a stepwise approach to looking at an ECG. Like any new skill that you learn, it's good to have a framework, a system that you can follow, and then you're not likely to miss anything as you do it. Again, like with many investigations, always good to check the patient's name and age, and check that you're looking at the right patient's ECG. Also, the fact that they're male or female and the age that they are will immediately make you think of different types of causes for abnormal ECG traces, or even what is normal within that age range. Then you're going to check the rate, whether it's normal, fast or slow. We're going to look at that in a second. Check the rhythm, whether in sinus rhythm or not. Check the axis. Is it normal or is it deviated? Is it left axis deviation or right axis deviation, or is it in the normal range? I'm going to check the intervals. Are they long or short? For example, the PR interval is very short. You may have that in Wolff-Parkinson-White syndrome. Prolonged in heart block. QRS interval, is it really wide? Prolonged again, is it some bundle branch block going on? The Q2 interval. Now this can be prolonged with certain drugs, and this is potentially dangerous, as I mentioned earlier. 6, check for ischemia or infarction. Again, you can look at the ST segment of the ECG, with depression or elevation. Also, you can marry this up with whether it's Q waves or T wave inversion. And finally, we're going to look at how to look for left ventricular hypertrophy, which is a more complicated skill. So here we have an ECG where we want to check the rate. Is it fast, normal, or slow? So an easy way to do this is to measure the number of big squares relating to these, the 5 small squares in a big square. What's the distance between the top, the peak of the QRS complex to the next QRS complex? And you can count the squares in between. That's 1, 2, 3, 4, 5, 6, 7, 8, 8.5. So the R to R wave is 8.5 big boxes. So a simple calculation is have the number 300 divided by the number of big boxes, assuming that the paper speed is 20 millimeters per second, and then that gives you the beats per minute, which in this calculation is 35 beats per minute. Now, as you're probably aware, anything below 60 beats per minute is what would determine bradycardia. So this is a patient in sinus bradycardia. And what about this ECG? How many big boxes is it between the two R waves? In the lower lead 2, it's 1, 2. Again, it's pretty consistent. The next one, 1, 2. And again, the next one is still 1, 2. So it's 2 big boxes between the R waves, and 300 divided by 2 is 150. The rate per minute here is 150 beats per minute. That's tachycardia. Then we have to ask ourselves, is this ventricular or atrial tachycardia? And we look at the QRS complex, and are they wide or narrow? Here they're very narrow. So this is an atrial tachycardia. Now, if you know something about ECGs, a rate of 150, until proven otherwise, is atrial flutter 2:1. Atrial flutter 2:1. So it's a problem with atrial tachycardia. Because it's 150, we assume that basically there are 2 P waves, which you can't see very easy on this ECG, per QRS. So what is the rate in this ECG? Well, it's roughly 1.5 boxes in this part, 1.5 boxes between the 2 RRs in the next part of the ECG. So 300 divided by 1.5 big boxes is about 200 beats per minute. These QRS complexes are broad, so this is a problem with the ventricular tachycardia. There's not any obvious P waves. If this is ventricular tachycardia, what do you need to check clinically? Well, we need to check whether there's a pulse. Is the patient having pulseless VT, or is there a pulse present? So now we're moving on from rate to rhythm. And when we're looking for rhythm, we're looking to see whether somebody's in sinus rhythm or arrhythmia, non-sinus. How do you check for that? Well, for every QRS complex, there should be a P wave. And between the R to R, it should be regular. And that would be what you normally find with sinus rhythm. So here, you see it's very irregular, the distance between the R waves along the ECG. Can we properly see a P wave? We can't really. It's all a wiggly line. It's not really straight, and then a P wave. It's kind of fluttering on the baseline there. There's not any obvious P wave. The QRS complexes are regularly spaced apart. This patient is not in normal sinus rhythm. In fact, they're in what we call atrial fibrillation. So just as for sinus rhythm, you need a P wave and then a QRS. A P wave followed by a QRS. A P wave followed by a QRS. Here we have a large QRS complex with no P wave before it. This has come early, it's premature. It's what we call a premature ventricular ectopic. Very common. Most of us have these every day, particularly in young people too. So the next question, question 4, is what does this ECG show? Again, we can see quite large QRS complexes, but they're of different heights. Some are very tall, some are smaller. This is what we call polymorphic, and this is ventricular fibrillation. So what would you do in this situation if you saw this ECG? Well, this is a shockable rhythm. You'd expect no pulse in this patient, and you want to get an automatic external defibrillator to the patient and shock them as soon as you can. So now we're going to go on to one of the most difficult things of ECGs, and that is, what is the axis? And what is the average flow of electrical current in the heart? What direction is it traveling? And is it in the normal position, the normal place? So it moves from a negative to a positive movement, and here's the thick arrow moving from the atria to the left ventricle. That's the main direction of the electrical flow of the current. This is a picture of a election night in the UK, and they use something called a swingometer as they have the counts of the votes coming in, and they say, oh, it's swinging this way at the moment. This is what it looks like at the moment with the politicians. So let's just give you the same idea. What's the average flow of current through the heart? Like I say, this is one of the most difficult things in ECGs. Don't panic. Here's a cat saying, don't panic, I'm a towel. So to work out the axis, you need a 12-lead ECG. You need to have all your electrodes around the 12 different positions around the body to work out your axis. The normal axis can be anywhere between lead 3 to just about AVL in this direction. So in this general direction, and that's still within the normal. Left axis deviation is beyond this way, that's that way. And right axis deviation, when the average current goes in this direction, it's beyond this area. So normal axis is here, left axis in this direction, and right axis deviation and the electrical flow is in this area, this quarter. Notice, for example, lead 1 is more positive, so it's more this direction, this side, rather than being negative, so rather than that way. Okay, lead 2 again is generally more positive, and it's going this direction rather than the more negative opposite that way. Okay, so that tells you which flow of the current. So again, just what I just said, the axis can be ranging from -30 to 120. That's normal. If the QRS in lead 1 and AVF are positive, the axis is normal, because then it's between those two. It's in this direction. They're both positive. Okay. So a quick look at the axis is to use leads 1, 2, and 3. And where is the QRS complex more positive? So it's more positive in lead 1. Okay. So it's more positive in this direction over here. It's then again a bit more positive in 2 than it is in 3. So then it's more likely to be there than it is in this direction. So it's kind of more between those two. That's the axis between lead 1, 2. Where is it more positive? It's more positive in 1 and 2 than it is 3. So the axis is around here. Left axis deviation. This time you're looking at lead 2, and it's quite negative. So lead 2 is in this direction. It's more negative. Now, it's still quite positive in lead 1. So it's still in that area. And AVF is again negative. So it's in that formation. So it's around here is the axis. It's deviated from the normal area. Right, axis deviation. Well, you've got a positive in lead 3, so it's in this direction. It's negative in 1, so it's more in this direction. And it's negative in AVL. So AVL is this way, and that's more this direction here. So it's deviated in a right axis away from the normal axis. So in summary, if the QRS complex in leads 1 and AVF are positive, then the axis is normal. But if lead 1 is positive and the AVF is negative, it's likely that it's left axis deviation. If lead 1 is negative and AVF is positive, it's likely you've got right axis deviation. So that's a quick summary, a quick way of looking for axis. Now, I'm not expecting you to know this, but it's just to give you information and to inform you how the steps of looking at an ECG are. And now we're going to move on to step 5, which is checking intervals. The first interval is looking at the PR interval, which is the start of the P wave to the start of the QRS complex, and that usually measures 3 to 5 small squares, which is equivalent to 0.12 to 0.2 of a second. The QRS complex relates to the start of the QRS to the end, which is the start of the Q wave, sorry, to the end of the S wave, and that's about 2.5 to 3 small squares, which is about 0.12 of a second. Now, the QT interval is the measuring of the start of the Q wave to the end of the T wave. And grossly, it's half the RR distance, depending on the heart rate. So it's about 11 small squares. We'll come to why that's important in a minute. So if you get a short PR interval, where basically it's going through the AV nodes very quickly, you normally get a delay, then you have a very short PR interval, and you get this delta wave, so it kind of takes off, like in the diagram on the right here. And yeah, you usually see a P wave, but it's very closely next to the QRS complex, and you get a tachycardia. Here you've got about 3 squares between the RR, which is about 100 beats per minute. If the opposite happens, where you've got a prolonged PR interval, as in a block, there's something blocking the electrical current getting through, usually like with the AV node, then if it's the same distance between the PR interval every time, as it is in the top diagram, it's 7 small squares as opposed to 5 small squares or less, then that's called first degree heart block. If you get an increase of the PR interval as it goes along the rhythm strip as here, then eventually the QRS complex will be dropped from the P wave. So here you've got an increasing length between the distance of the PR interval, and the pulse will go something like dum, 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 drop a beat, and then it'll carry on again. So the spacing of the pulse will be increased as well as you check it. Other types of second degree heart block include Mobitz 2. So it's a fixed PR interval, So the P wave comes in at the same time every time, but the QRS complex is sometimes dropped. That's a Mobius type 2. The third degree heart block is there's no association between the P and the QRS complex. They're completely random, and there's no obvious pattern to when a QRS comes in, and that's complete heart block, and that's worrying, and that patient needs a pacemaker as soon as possible. The next interval we're looking at is the QRS. Now that's usually in right or left bundle branch block. This is small print, but it's just to let you know. So you get an RSR pattern, this RSR pattern in V1, and then you get a QRS in V6 in the right bundle branch. In the left bundle branch, you get a deep R, you get a small little R and then a deep S, and then you get this like M shape for the in V6, the Morrow sign as they call it, M for Morrow. And these are different causes for right and left bundle branch block. I'm not expecting you to know this, but this is just for completeness. And here we have the thing I want to talk about is the prolonged QT interval. It's more than half the RR distance between the two RR waves, and so it's prolonged. And this is a risk factor for faints, blackouts, and sudden death. And it's associated with some drugs, even common drugs like antihistamines, some antibiotics, tricyclic antidepressants, other depressants, antidepressants, and even antipsychotics, all common in Jordan, and a lot of them just given by the pharmacist to patients. So be aware that these drugs can prolong the QTR interval, which in turn is a risk for faints, blackouts, and sudden death. So this is a classical progression of an MI, and the ECG changes that happens. First of all, in the first few minutes, you get this peaking of the T wave. Then, in minutes to hours after the event, you get the ST elevation. See how elevated it is above the baseline here, and that's ST elevation, classical acute coronary heart attack. Then you lose the R wave, and you get the beginning of the Q wave forming after hours to days. Then you get T wave inversion, the opposite way around than it normally is after a few days. And then often after days, weeks, and months, you get the normalization of the T wave back to normal, but you're left with this Q wave often. That's the classical picture of MI and how the waves progress in the ST segment, and then what happens with the T wave and the Q waves that form. So next I want to say which leads relate to which part of the heart. Well, as it shows here in this diagram, in blue, the lateral leads correspond to V5, V6, and lead 1. The inferior leads refer to leads 2, 3, and AVF, and the anterior leads V1 to V4. Often people include V5 and V6 as well. Well, why is that important? Well, it relates to the arteries and which artery corresponds to which part of the ECG. So this is a diagram of the coronary arteries. Here you've got basically the inferior leads relate to the right coronary artery. Anterior wall relates to the left ascending descending artery, that's V1 to V4. The lateral corresponds to leads 1, V5, and V6, and that more relates to this area over here, the lateral wall, and that's more the circumflex artery. So let's look at some ST segment changes. Here we've got normal. and compare that with ST depression going on here. So you see it's below the baseline as you get in the normal trace. It's ST depression, and that is classical in myocardial ischemia, particularly if someone's doing a treadmill test. So you might see ischemia arising and get chest pain after doing several minutes of exercise. Or it can also occur in a non-ST elevated MI, so just be aware of that. Most MIs present as a STEMI. We get ST elevation. You see that on this graph here, how elevated it is above the baseline. It's at least 3 to 4 squares above. It's what we call tombstoning. This is a classical British, I suppose, tombstone. You get that shape. And so the criteria, if you want to be strict about it, is at least one small square in 2 subsequent leads in 2, 3 and AVF. Remember, that's the inferior leads, or 1 in AVL, which is the lateral leads. Or if you look at the anterior leads, it's got to be 2 small squares, a bit more elevation on the anterior leads between V2 and V6, or a new left bundle branch block. And now we're going to move on to just the last step in an ECG is looking for left ventricular hypertrophy. And this is just for your information. I'm not expecting you to know this, but it's just to say these are the tips for helping you work out whether a patient has left ventricular hypertrophy, often from hypertension, or it could be part of the congestive cardiac failure patients developed. So the simplified criteria is the deepest S wave in V1 or V2 plus the tallest R wave in lead 5 and V6 if that measures to more or equal to 35 squares and or the R in leads AVL is greater than 12, then basically you meet the criteria for left ventricular hypertrophy. In a patient that is over or equal to 35 years old, and there may also be left ventricular strain. Okay, so basically in this diagram you've got 20 squares, small squares of in V1 as opposed to 14 in V2. So you take the bigger of the two, that's the 20, add that to the tallest R wave in V5 and V6, and that's in V5, that's got 23 small squares. That gives you a grand total of 43, which is over 35. And so that meets your criteria, assuming this patient's over 35. I don't see any left strain pattern. Often you get depression, ST depression in V5 and V6, but I don't see that in this case.